Welcome to our member-led session, Tackling Inequalities, A Journey to Partnership Working, which has been designed by Resuscitation Council UK, one of our National Voices members. This morning, in her closing remarks, Sanisha, our expert by experience, identified that one thing GCSE organisations can do to combat racial inequality in health is to go out to community groups and build relationships, to open doors and to stop gatekeeping. To me, that remark seemed particularly pertinent to this session, so I thought I'd just raise it here, and I could never be as eloquent as she was, so I encourage those of you who weren't there to go back and watch the YouTube recording when we share that later. Before handing over to Resuscitation Council, I just need to go through a little bit of housekeeping. Now, we've tried to make this conference as accessible as possible. You can see in my name, I have changed my name to identify my organisation and the pronouns I like to use. If you're comfortable doing so, please feel free to change your own name. We have a palantypist joining us for the entirety of the conference, and to access the live transcript, please click CC in the taskbar at the bottom of your screens. For those of you with a BSL interpreter, please alert National Voices members in the chat if you've not already done so, and we will pin and spotlight them for you. We've enabled the chat box, so please talk in the chat, share your ideas and your reflections, and also ask the National Voices team any questions you need to do so. My colleague Ella will be pasting a link to a collaboration document, whereas if you'd like to get involved in any of the work we've shared throughout this conference, or if there are any organisations you want to link up with, you can go into that and share your details. And for the Q&A later in this session, please type your questions in the Q&A box, which you can see at the bottom of the screen, and I will pick up on those questions and where possible address them to the panellists. Now over to James Kant, CEO of Resuscitation Council UK.
Thank you, Jess, and thank you, National Voices, for this opportunity to be with you here today. Thank you so much for all of you who have joined. We recognise just how much you have going on in your day-to-day business, and we really appreciate your time. Next slide, please. We've got a brilliant lineup today, but we do after I stop talking. After myself, you'll hear from Professor Rantala from the University of Bedfordshire, and what we want to do today is we want to talk about resuscitation. We want to talk about some of the specifics, but we want to talk about it in a wider perspective, in terms of wider inequalities. And Gutch will give a wonderful overview of that and broaden it out. After that, my colleague Andrea Tofa, Director of Engagement and Influencing at RC UK, will talk about some of her experiences in her previous roles within government when she was working in terms of blood services, but also particularly in terms of organ donation, to hear some of the key messages that Andy has managed to derive from her career so far, and some of the difficult learns that she's had along the way. And then we will go to Dr. Shakil Ahmed from the British Islamic Medical Association, and Shakil will talk about some of the practical activities that BIMA are undertaking just now, really to get the message out there. So I just want to begin by talking a little bit about what sudden cardiac arrest is. And I should say that I'm not a medical doctor. And like many of us who come into this field, there is an element of confusion that I experienced when I first joined. So some of the key facts around sudden cardiac arrest. Well, in terms of how many times it happens out of hospital in a typical year, it would happen sufficiently often that you could fill a typical football stadium with the number of cases that we have. And if we look to the second picture, you'll see a very typical row of family houses, because one of the key elements we have to understand in all of this is that even before COVID and lockdown, more than 80% of sudden cardiac arrest took place in a domestic situation. So what we're talking about here today are friends and family. We're talking about how you can have the opportunity to save a life, and it's really very much at home. It's very personal to me, because this is what killed my mum, and my dad didn't have the knowledge or skills and did what many people would. He phoned the paramedics and waited. And one of the key messages about all of this today is we cannot afford to wait. And it doesn't have to be this way. The next picture as we come along is of Starbucks, which, as many of you will know, has its origins and home in Seattle, in Washington State in America. And survival rates in the US as a whole are not great, But what you do find are pockets of absolute excellence, and Seattle is one of those. And what we can do is we can look to places like Seattle and find some of their best practice and copy it. That's what we want to do. We want to find the best practice. And so much of what we're here about today is also learning from your best practice. The next picture comes along and shows us CPR in schools. This is absolutely pivotal, and we are so excited that CPR has now been put on the national curriculum in England. It's already on it in Scotland. Within the next few hours, it should be formalised in Wales as well. And we're hoping that a private members bill in Northern Ireland will also put it on the school curriculum, because like so many other things in terms of public health, getting the message across to young people to take home to their family is absolutely pivotal. And we know that it works. The last picture is of Norway. In the same way that Seattle excels in terms of survival rates, so do our friends in Scandinavia. You have got 5 times better a survival chance if you have a sudden cardiac arrest in the likes of Norway or Denmark than you do in the United Kingdom just now. And so much of that is down to the normalisation of CPR. And again, pivotal as it's been so much part of people's training in school. Next slide, please. So, important to understand what a sudden cardiac arrest is not. And here, again, I put my hands up and say, this is coming from a total non-clinician. It's not a heart attack, although somebody having a heart attack can move into a cardiac arrest. A heart attack is much more about a blocked pipe. It can also, these blocked pipes, if they're in your head, can also lead on to stroke as well. Sudden cardiac arrest is not the same as a heart attack, nor is it quite the same as heart failure. My dad has heart failure, which is an understandable aspect of aging. He's 84. And just like the old car engine, the pump that is the heart just doesn't quite have the power that it used to have. It can be an aspect of aging. It can also be some of the damage to the tissue that can happen as a result of a heart attack. Both of these conditions are incredibly serious, but nothing is more serious than a cardiac arrest. Next slide, please. A cardiac arrest is a power outage. The heart has stopped. The person has effectively started dying before you. And the single most important determinant of their survival is what people around them do in the here and now. And the here and now is essential here. If we didn't need any reminder, but the last 12 months have taught us just how incredible the clinicians are in our hospitals, how incredible our paramedics are. But with a cardiac arrest, if you wait for the paramedics to arrive in the ambulance, very often it will be too late. For every minute that goes past, it's estimated that somebody's chance of survival reduces by 10 minutes. And if we think about the challenges of an ambulance getting to the scene within a busy town or city, or getting to the scene in a remote and rural area, we know that these are 10 minutes that person cannot afford to wait. Next slide, please. The chain of survival. If you look at the chain of survival, you will see that some of the key elements within the chain of survival actually fall to us as lay people. And so much of it is so simple. The heart is a very, very big pump in the center of the body. And effectively what we need to do is take over the operation of that pump. That's why you hear about putting hands in the center of the chest, sing it to the same kind of beat as Staying Alive, and pumping hard and fast to take over that process. Always call 999. They will talk you through, they will tell you everything they need to do. The call handlers are absolutely fantastic. Call for help and never leave the person alone. And if you can use a defib, and they are so simple to use, the minute you open it, it starts talking to you and telling you what to do. You will increase the person's chance of survival by up to 70%. And all of this will have happened in 10 minutes before the paramedics ever arrive. So the key message we have today is we must be involved. In the same way that we would never walk past if somebody was drowning and wait for the paramedics to come, this person has effectively started to die in front of you. And what we do is pivotal in that way. Next slide, please. So, sudden cardiac arrest discriminates, and COVID has made things worse. In the same way that you look at major disease conditions, whether it be cancer, whether it be stroke, whether it be diabetes, whether it be respiratory, whether it be heart disease as a whole, when we look at the statistics for sudden cardiac arrest, what we see is that how it impacts people depends on who you are. So depending on your socioeconomic status, depending on your ethnicity, that will impact upon your likelihood of suffering a cardiac arrest. It will impact upon the likelihood that somebody will do CPR. and therefore will impact upon your survival chances. But it doesn't need to be this way. As we've seen already, what people around you do in those first 10 minutes are going to be pivotal. And one of the big challenges we have, obviously, because of COVID, is people are less willing to actually intervene. There is that fear of infection. And again, if that is a fear that people have, what we said is very, very clearly, put a tablecloth, put a mask over the person, and that significantly protects you as the rescuer in that way. Next slide, please. So what does this mean for resuscitation? Why are we here today? What can we learn? Next slide, please. The way in which we're coming to today's session and the way in which we want to work in partnership moving forward has got so much in common with how we advise people to do CPR. Find experts willing to share their skills and experiences. So we have clinical skills. That is our history. We were created by clinicians 40 years ago. What we've done in recent years is we've had much more of an outward-facing perspective, but we want to do so much more of that, and that's why we're here today. That's why we're actually here to ask for your help. Learn simple but vital truths. I hope that over the last few minutes, I've told you just how simple CPR can be, but we're here also in the next hour to hear your simple but vital truths for us as an organisation. Work as a team if you possibly can. CPR is a really, really physically demanding thing to try and do, and it's always best if you do it as a team. Similarly, us UK is a tiny organisation. We know we can't do it on our own. That's why we're here today. So it's now my very great pleasure to introduce Professor Rantala from the University of Bedfordshire, who, as I say, is going to take us to that wider perspective and really place it in terms of what we need to do, not just for resuscitation, but for wider public health. Gurch, thank you.
Thank you, James, for setting the scene. It's truly a pleasure to be here today to share some reflections and just to sort of state, as well as sharing my reflections, I'm really keen to learn from everybody else because I suspect there's more to be garnered from our collective discussion. So I've deliberately framed my talk about a journey to partnership working. And I deliberately use the language of journey because when you think about a journey, you first have to decide about where you want to get to. And sometimes you have to accept that you're not sure where you want to get to, but you just want to go on a journey. And also, like lots of journeys, and maybe mine have been more adventurous than others, you end up taking a few wrong turns, you take a few sort of U-turns, you encounter roadworks, you encounter delays, and on a good day, it's a smooth journey. But the point I'm making is, if you really want to tackle inequalities, you have to go on a journey, and you have to go on a journey in partnership. And unless we do that, in my humble opinion, I don't think you can tackle inequalities. Next slide, please. So just a quick background. So I'm Director of the Institute for Health Research at the University of Bedfordshire. And just to sort of flag up for the people who know me, I'm only interested in doing real world research. So publishing papers and delivering grants is all well and done. But unless our work has impact on policy and practice, you will find that I will sort of want to take a different journey than those people. And I'm really lucky that we are committed to research-informed teaching. Next slide, please. One of the things I want to highlight is health inequalities don't sort of begin at a particular age. They take place at all sections of the life course. So essentially, what I'm really proud of is our research ranges from literally preconception all the way through, you know, to childbirth, maternal health, child health, adolescent health, adulthood, and older people's health, and also end-of-life care. And I think it's really important that when we think about health inequalities, we think about that in the context of the whole life course. Next slide, please. And I think that's really important because when you're thinking about research, you need to think about it in terms of the factors that determine health and health behaviour within the context and the systems and the political situation that we work in. And I say that because I'll later talk about COVID. You can't think about tackling inequalities unless you think about the political context in which people work. Someone's usefully moving my slides. Never mind. I think it's vitally important to think about that, and also the political situation. So I'm privileged to do work not just in the UK but across the world, and therefore some of the solutions we may have in the UK may not necessarily apply to other countries because their health systems, their local context and their political situations may well be different. So we must always be mindful of this wider system that we all work in. Next slide, please. So this is just to sort of show you that when I do work, I work with a range of funders who make sure that our work has impact on policy and practice. And I'm really lucky that, you know, I work with a really talented group of individuals and students. Next slide, please. This is my personal selfish cheer me up slide. So once lockdown is over, this is the privilege that I have of going to work at my campus. And I try and put this slide in all my presentations at the moment, just to sort of remind me of what my normality will look like. So if you can imagine, use your imagination, normally our PhD students are milling around these grounds. We do lots of walk and talk meetings. We have barbecues in cold, wet weather as well, because that's quite normal in this country. But that was just my sort of selfish slide to me, just to remind myself where I will be hopefully in a few weeks' time. Next slide, please. So in terms of health inequalities, I don't really want to tell people what we already know, because I think there's been so many reports on this, but a very high level summary is this. We know for a fact that health is unequally distributed in the UK. That's just a fact, and I don't think we should waste time in disputing that. We also know that health varies between and within all ethnic groups. And we also know, if you look at the evidence, that if you really want to focus on health inequalities, you need to look at focusing on social class and ethnicity. Next slide, please. And just to sort of illustrate the point, there's been numerous government reports in the UK, and these are just sort of 5 I've listed here over the last 20 years that have time and time again highlighted the fact that there are health inequalities in the UK, and we need to produce tailored solutions working with trusted messengers. And our challenge really as a country is, when are we going to move from just producing reports to actually acting upon them? Next slide, please. And I think one of the things we need to recognize is this whole notion of intersectionality. So we know that health inequalities take the form of a social gradient. So for example, we know that there is variation in terms of health at a very crude level within and between ethnic communities. So for example, my parents came from India, and I know that most of the health survey and health outcomes data in the UK shows that on the whole, British Indians tend to be a bit healthier compared to British Chinese, British African Caribbeans, British Pakistanis and Bangladeshis. And we know that, and we need to recognize that. Therefore, you know, we're not, ethnic minorities are not a homogenous community. Hence, we need to focus at a much more granular level. And one of the things I'm very keen that we don't forget about is also the white working class communities, who often get left out of this debate. Next slide, please. I would say this as a public health professor. I think one has to recognise that our health is influenced less by the health service, but more by the wider determinants of our lives. So for example, all of our life chances are very much influenced by our childhood circumstances, our education, our parents' employment, our working and living conditions, as well as our access to health and social care services. But we need to recognise that if we really want to improve any country's health, we really need to invest in terms of housing and living conditions and employment prospects and access to a good education. And sometimes in a lot of countries, and I include the UK in this, we take a very medical approach whereby we focus so much attention on the health service and we forget that actually it's people's living circumstances that are causing them to have ill health in the first place. Next slide, please. So I just want to use COVID as an example purely because obviously it's current and it really has had tragic consequences across the world, but significantly in the UK. And it does show health inequalities in a very, very significant way. So we know, for example, that age has been a huge risk factor, and that's always been the case with many infectious diseases and pandemics. We also know that ethnicity is a risk factor in terms of Bangladeshi and Pakistani communities and African and Caribbean communities being at more risk. We also know that gender is an issue with, although the case rates are higher amongst women, the death rates are higher amongst men. And we also know that comorbidities are much higher. So in a sense, I guess, you know, for me, the irony of all this is these are known issues around pandemics anyway. So if you look at the history of Spanish flu, plague, SARS, MERS, etc., we always know that issues around age, comorbidities, population density are always risk factors. And the challenge for any country and any government is how do you mitigate and protect people with those risk factors. Next slide, please. So for me, and thinking about this audience, I think we have to think about, if we're going to tackle inequalities, how do we do this in partnership? And this is why I go back to the point, it's about journeys. So we have to recognize that one, if we're going to go on this journey, it could be a sticky journey. And it may not always present, you know, lovely scenery. We may see things on the journey that we don't like. And the question to us all is, do we want to do something about it? So, for example, when we look at organisations and the charity sector, the NHS sector, social care sector, I would say we need to look at the evidence about the workforce data. Is our workforce as diverse as it could be at all different levels of the organisation? And I mean from top to bottom. Are our trustees, our volunteers, our clients as diverse as they could be? And are they represented at all different points of our care pathway? And again, if you look at COVID, you can see that that's not always been the case. So that's something we all need to reflect upon and think about, you know, the fact that that journey may show us things that we might not like, but the challenge to us all is, what are we going to do about it? What action are we willing to take? And for me, it's all about building trust. We need to work with communities to build trust. Trust cannot be earned overnight. It takes time. It takes relationship building. It takes investment. And for me, that means we've got to develop tangible outcomes in what we're trying to achieve. And it means that we've got to start thinking about using evidence to then mobilize action. And I think we've got to move away from just thinking about inequalities in terms of ethnicity. We have to think about an intersectional approach where we think about age, gender, ethnicity, social class, occupation, all of these things and how they interact. And for me, the challenge is, as I said, is about how do we get the policy recommendations that we've seen for nearly the last 20 years, where we say we're going to do this in partnership, and we say we're going to co-design solutions. And I wrote about this recently in the British Medical Journal. The reference is here, and you're welcome to have my slides. But we then fail to do it, or we don't do it in a meaningful way, or we don't do it in a resourced way. But I do want to sort of finish on a high and talk about something where I think, you know, we did something wonderfully well, where tailored messages and trusted messengers have really worked well. And that's the Organ Donor Community Investment Scheme. Next slide, please. So very briefly, in the UK, we know that there's a disparity between the waiting list for transplants, in that there are disproportionately more ethnic minorities waiting for a transplant than there are donors. Next slide, please. And when we do the research, and this is about generating the evidence, we know that when you talk to members of the public, it's because there's a lot of fear and perceptions out there, and also there's actually solutions here. So a lot of people fear that staff won't try and save their lives. They fear there's racism may have a role to play. People are concerned about burial and cremation rights being delayed, but also people are worried about religion being a risk factor. Next slide, please. So the solution is about partnership working, and I think with organ donation, you know, I want to give credit to NHS Blood and Transplant, who've actually put money where their mouth is. They've actually invested in a long-term strategic approach to developing partnerships. So we've developed faith and community partnerships. Next slide, please. And we've developed a set of meetings with faith leaders. Next slide, please. And that's led to an action plan, which has been partially resourced, not fully resourced, but like I said, it's a journey to getting there. Next slide, please. And most recently, it's culminated in the launch of a community investment scheme, which was launched 2 years ago, whereby community organisations at local level can apply for funding to develop their own tailored solutions to suit their audiences. So this is just one example where we can start to develop trust and start to develop a partnership approach. And this works with different ethnic and faith communities. And at this point, I'm going to hand over to Andy, who can talk to you more about this. And I'm happy to take questions at the end. Thank you so much for your time.
Thanks, Gert. So as Gert just said, I'm Andrea Topher, and I'm going to spend just a few minutes talking through the way we went ahead setting up a community investment scheme at NHS Blood and Transplant. It is a bit weird talking about this now, because I now work at Resuscitation Council UK, but I used to be the head of organ donation marketing at NHS Blood and Transplant, and that's where I came across people like Gert and Rohit and Amjad and others who I know are here today. The situation there at NHS Blood and Transplant was very different to where I am now, as Resuscitation Council UK is a much smaller organisation without the resource and budget of a government arms owned body to be able to set up a community scheme. But the principles of partnership and collaboration are very much relevant to where I am now, and was really a theme that came out of this morning too. Thanks. Next one, please. So before I go into the community investment scheme, it's worth touching upon why we set it up. We were already doing some work with Black, Asian and minority ethnic communities. We're engaged with the National BAME Transplant Alliance, an umbrella organisation that was originally set up and funded by the Department of Health to address inequalities in certain ethnic communities. We regularly and widely published a report every year that focused on donation and transplant rates between Black, Asian and minority ethnic communities. Amjad Ali, who's here today, a Muslim kidney patient with a genuine interest in bringing about change in his community regarding organ donation and transplantation, was leading on engaging the Muslim community to update a fatwa that addressed the permissibility of donation, and that was an action point from the Faith Action Plan Gert talked upon. We were developing real people stories, we were providing resources to communities, and we were tailoring press releases, but it wasn't enough. Thanks very much. So there were shortcomings to the approach that we were taking. It was very centrally delivered by an NHS organisation, but as Gert said, not everyone trusts the NHS. There were real fears, and we were missing out on opportunities to promote and join up with initiatives that were happening on a local level to kind of amplify them on a more national level. We didn't have enough stories from Black and Asian communities of people who've needed a transplant or had a transplant or died waiting for a transplant or donated an organ. And so to be able to normalise donation, we really needed those stories, but why would people share them with us? When we did have those stories, we pushed them out on our own channels. It was highly unlikely to reach the communities we wanted them to. We didn't know whether we were nuancing campaign messages well enough or materials in the right way, because we really needed to listen to those communities more. We were too often fielding white spokespeople for media, and we had a shortage of materials in commonly spoken languages. Thanks. So providing funding to community organisations was something groups had been asking for, and it was something we'd wanted to do. We'd never had the funding to do it until 2018. For many community organisations who wanted to do more in this area, Being able to be funded and supported was a barrier, and we wanted to change that. But it was really important to me and others that we created a fair and equitable way to distribute funding. But where on earth to start? Quite frankly, I didn't really know. I did know, though, I didn't want to reinvent the wheel. And I think that's what this conference is so important about, sharing ideas. So I explored with the team what different organisations have done, such as the Ministry for Housing, Communities and Local Government, and also the MBTA had done a commission model around living donation a few years before, and we took lots of learning from what they'd done. As only a small proportion of our team came from the communities we wanted to engage with through the initiative, it was really important we built trust of community organisations so they felt it was something they could and should apply to. But would they just listen to us, a majority white team? So we set up an advisory group of Black, Asian and minority ethnic donor families, transplant recipients, clinicians, GERCH, Amjad, the diversity lead nurse, the MBTA. And working together with that advisory group, we were able to build a scheme, taking advice and support from things and learnings they had from other areas of health and other areas of society, but also kind of feeding into what a good project could look like. And we were able to work together to agree the funding criteria, documentation, and how we'd measure successful delivery. I can't emphasize enough how much getting buy-in, how important getting buy-in was, both from our funder, the Department of Health and Social Care, but also internally. You know, we are always trying to push a scheme through that was very different to what the organisation had done before. And it was really important I had the confidence of the organisation that if we were going to promote this funding opportunity, it was going to reach the community groups we wanted it to. So it actually was a success. Thanks. Next slide, please. So I'm really pleased to say that we launched the first scheme in September 2018 and funded £140,000 worth of projects across 25 community-led organisations across different faiths and ethnicities across the country. Thanks. So over the next 6 months, next slide, please. Over the next 6 months, as a team, we provided support to the projects. So we didn't just leave people to it. We really were trying to work in partnership. Being there as a sounding board to provide advice on the facts around organ donation, because a lot of these groups weren't necessarily where they were coming from, wasn't organ donation, it was the access and the trust they had in their communities. We were able to provide materials, links to hospitals, and the advisory group we mentioned before would often go out and talk within their own community at events and sessions that were set up by the projects. We were able to provide evaluation support, and we'd have regular catch-ups on a quarterly basis with the projects to, to check through and see how they were getting on. Thanks, next slide, please. So the first set of projects came to an end in June 2019. And by that time, the world had kind of changed because we were now at the point where we'd launched a campaign to educate and inform the public about a law change. So we knew we needed to carry on working with communities, but we also knew that it wasn't only about educating and informing people about the facts of donation and addressing barriers, concerns, myths and misconceptions within certain communities, but it was also about addressing them around the law change. So it's important not only that we learned from the first year of the funding projects and spoke to projects about things we could do better, but it was also important that we thought about how the situation had changed and what we wanted projects to do moving forward, so we were all moving in the same direction. Thanks, next slide, please. So really pleased to show you some media coverage from the second funding round, and you can see there were a range of different projects. Next slide, please. So what are my final thoughts? Setting up this scheme was far from easy, and there were lots of late nights, stressful moments and moments of self-doubt where I'd ring people who are here today going, are we doing the right thing? Are we going about it the right way? But we knew we were on an important journey. We knew we didn't know the answers. We didn't have the golden nugget that was going to suddenly address the health inequalities and suddenly bring transplant rates for Black and Asian communities up to the levels of white people. But we needed to be open to ideas and accept criticism and feedback, both from people who were funded and those who weren't. We wanted to build trust and long-term relationships. This wasn't going to be something that was going to change overnight. We were starting a journey that organisation is still on today. So has it made a difference to saving more lives in Black, Asian and minority ethnic communities? Well, the scheme's only run since 2018, but over the last 5 years, we have seen a significant increase in consent rates from Black and Asian people to donate their organs after death. So while Resuscitation Council UK is different in size, scale and resourcing, the principles of partnership widely apply to the challenge around increasing cardiac arrest survival rates and reducing the current inequalities. So I'm now really pleased to hand over to Shakil Ahmed from the British Islamic Medical Association. He runs the BEMA Lifesavers programme, and he's going to talk to you about the work they've been doing since 2014. Thanks.
Thank you, Andy. So thank you first of all to everyone for being part of this conference and for giving me the opportunity to share with you our journey that we've been on for a number of years now in tackling health inequalities with specific regard to CPR and community CPR levels. So I would like to start by greeting you with Islamic greeting of peace be upon you. And I'll talk about BEMA's Lifesavers project that has been ongoing for a number of years, and hopefully it will give you some idea of sort of the steps we took, but also what are the lessons we learned, and if they can inspire someone else to undertake the same journey, then I would have done my job today. So next slide, please. So I'm Shakil Ahmed. I'm a consultant child psychiatrist, and I'm part of the British Islamic Medical Association, which is a group of doctors, healthcare professionals, nurses, dentists, occupational therapists from across the UK, and with a common vision of unite, inspire, and serve. The next slide, please. And in order to achieve this vision, we undertake a number of projects, of which Lifesavers is one. And we have a tagline of save a life, save mankind, which is part of the quote from the Quran. So next slide, please. So what other projects does the BEMA do? So we undertake a lot of different projects, including organ donation, about COVID, about vaccinations, and Lifesavers is one of those projects. Next slide, please. So how did the Lifesavers start, and how long did it take us to build this project? So as you can see, it started a number of years ago in 2014. And a bit like Parkrun, it just started with a few friends, few doctors, met up in a local mosque and decided that it was time to teach members of the community how to do CPR. And it started with 3 mosques and only 200 participants. And by 2019, it had grown to 114 mosques with over 800 volunteers and over 4,000 people who learned just that year alone of how to carry out CPR if they found a member of the public in a public place. So next slide, please. So the project has grown and it's international now. As you can see, there's lots of other countries across the world who took part last year, and year on year, this project is growing. And why have they taken on this project? Because they were so inspired by our project. So next slide, please. So as part of this journey, it's not just about taking our own journey, but also inspiring other people to join us and come along and also take action to address some of these health inequalities. So this is one of the quotes we got from an attendant. So the teaching was very clear and concise and was delivered in a fun but professional manner in which the message was clearly communicated. And again, we focus on a really simple techniques of chest compressions, recovery position, and how to deal with somebody who is choking. And 1 year, we also taught how to deal with somebody who is bleeding. So next slide, please. So how do we engage people with this project? So it really starts with the leadership, as with everything else. And the leadership, we're connected from the grassroots, so which is the volunteers at a particular mosque, which form a mosque team, and then it feeds into the regional team. So across the UK, we have a number of different regional teams, and we have regional leads and deputy leads from each region who form the national committee team. So I was a national director for Lifesavers last year, and as part of the national team, I had a number of regional leads on my committee. So we really engage. So we link grassroots all the way to the national teams, and it's comprised of students, healthcare professionals from different backgrounds, GPs, consultants, trainees. And in terms of our volunteers, we're all inclusive. We encourage people who've never worked with any other project before, and also people with experience, and we mix them. and we help the seniors to mentor the students. And we provide all the training and learning for all of our volunteers. And we, as a national team, we organize and do the training packs. We create all of that. So our volunteers really, the only ask we have of them is that they come for a training session for 1.5 hours. And then in September, once a year, they teach again for 1.5 hours, 2 hours, and that's it. But behind the scenes, the leadership team will be working throughout the year in preparing and organizing the event. Again, we engage mosques by using members of the community to approach the mosque leads to allow us to advertise the event, but also hold it in the mosques. And you can see an example of some of the slides we have in our presentation. And you can see we've made it very cultural and religiously specific. And again, it's with the aim to engage people. So this feel that it is relevant to them. CPR, and it's not something alien and it doesn't affect them, that we want people to feel engaged and part of this. So next slide, please. So how do we make the project sustainable, unadaptable? So as we saw in one of the earlier slides, that it started in 2014, and we had a really successful formula refined year on year. But after 6 years, we hit the pandemic last year. And some team members even suggested we shelf the project for a year and then pick up back in 2021. But we were quick to innovate. We knew the health inequalities were only worsening because of COVID. So we developed a virtual offer because we knew we wouldn't be able to go to mosques in person. We created working groups to investigate which are the best platforms to deliver this online and how we're going to do that. In the end, we chose Zoom, mainly because of its breakout room features. And clearly, all the participants wouldn't have had mannequins at home. So we developed a package of how to train them on how to learn CPR on a pillow or a teddy bear. So we did a 3-step teaching method. We showed them that we took them through the theory by presentations. We showed them the video of demonstrations of each of the skills. Then one of our instructors showed live on camera how they would approach the scenario of, for example, somebody's collapsed. And then we used the breakout rooms with 4 or 5 people, learners with one teacher, and they practiced and they got live feedback from the teacher. So we catered for families, different languages, and people from different regions being taught by people from the same region, by the same gender, and also speaking the same language. And in total, we had 236 volunteers and over 500 learners. So next slide, please. So this is a screenshot of what it looked like in person on the day. So next slide, please. So what are the key lessons? So in the interest of time, I am speeding through the presentation, but some of the key lessons were that we have to think holistically about the project. And the key aspect of it is that it will take time. It is a journey, as it's been mentioned already. And we have to really start with a seed. So what is the vision? What is it that we are trying to achieve? And as mentioned before, in BIMA, our vision is to unite, inspire, and serve. So we don't do lifesavers just to teach CPR. It's a strategy to unite people, to inspire people to learn, and also to serve our communities. So coming from the seed, you have to have a strategy, which is have a simple plan, a holistic plan, and just start. There's no point thinking about this for 5 years or 7 years. You just start with something small, like 1 mosque or 3 mosques, and then it will just grow and you can refine the project over time. And you have to feed it with a learning culture. So every year you're learning from your mistakes, from your successes, and you're also delegating tasks to other members of the team. So over time, the leadership team grows. And in terms of what is the leadership strategy we use very encouraging, positive leadership strategies. Our aim is to help grow new members of the team, and we mentor junior members of the team. And really, we have people from the community to teach the community, so we have a good knowledge of terrain. We know how to approach a particular mosque. we know how to approach particular, say, women, children, etc., to engage them, and how to approach students, for example. And I think that's the key strength, is if you can get volunteers from the community and engage them, inspire them, and help them to engage other members of the community, that's a recipe for success. And our roots are really to address inequalities and to serve our community members. And I've put this term Sadaqah Jariyah, which is an Islamic term. And what it means is, if we do a good deed, as long as that good deed benefits people, we keep getting reward. So I might be a national director last year, but if I can inspire a few people, even 2 or 3 people, to take up this challenge over the next few years, then I'll keep getting reward as well, even though I might not be involved in a few years' time. So really, the key strategy at the end is to learn, adopt, and refresh every year. So the project is active from March till October, and the actual Lifesavers happens only once a year in September. And then from October till March, again, the team is disbanded, everyone has a break, and the leadership team reflects and learns from it. And for the next year, we change our strategy according to the lessons of the last year. And then we start all over again in March. So next slide, please. So this is a quote, part of the quote from the Quran, and whoever saves one life, it is as if he had saved mankind entirely. And that really is our mission in Lifesavers, is to be able to save mankind again and again. And if we can, through this project, if we can inspire other community members and other people to start their own journey, then I think I would have done fulfilled 2 key aspects of our BEMA's vision of inspiring and serving others. So thank you. So our website is britishima.org.
Great, thank you, Shaquille. That was such a constructive and practical presentation. We're going to go on to a very quick Q&A shortly. Unfortunately, we are running out of time. But if you have any burning questions, put them in the Q&A now and we'll try and get to them. But before we do that, my colleague Laura is going to post in the chat a link to Mentimeter, which is an interactive tool we've been using throughout this conference to gather the opinion and the insight of our attendees. And the question will be, what do you think the priorities are for partnership working to address health inequalities around sudden cardiac arrests, bystander CPR and survival rates? So if you just answer that whilst we're doing the Q&A, we'll show you the results very shortly afterwards. Now, we've had a few questions through, one of which is around funding, and then it's come through that, see, what we're talking about needs to be funded, and that there is the possibility for larger charities to be generous with their funding in building partnerships. I wondered if, Andrea, maybe you could elaborate on what you would see, potentially some of National Voice's larger members' roles being in using their funding to share it and to build partnerships with smaller community organisations.
I think there's a very real risk that if charities carry on doing what they've always done, nothing's going to change. And I think we've all played nicely at trying to work in partnership before, but actually, you know, as Shaquille's just shown, trusted messages come from within communities. And those community groups are often, as Shaquille's just said, voluntary, doing it in their own time and doing it because they care. And sometimes, as the Organ Donation one showed, sometimes it's just being able to fund sandwiches for an event to get people there could be the funding blocker. We're often not talking about huge amounts of money, but by getting the right structure in place to support it, you can show, and we've seen with like BEMA were one of the organ donation projects as well, is that they can do so much with that support and with some funding. And you know, the large charities tend to have the infrastructure, tend to have the marketing support, tend to have all those kind of parts of a charity's infrastructure that you need to set something like this up. So I think there is a duty upon the voluntary sector to do much more of this.
Shaquille, would you like to come in on that?
Yes, I think it's a really important question, because in order to make the project sustainable, you need some funding. And although our Lifesavers project, we don't get any funding externally, and as an example, it cost us about less than £1,000 last year to do this. And the year before, probably £800 to teach over 4,000 people. And I guess the funding is coming from volunteers, you know, doctors, students, healthcare professionals giving up their time. And that's really our funding. And I think funding can take time. And I think it's important to just start on a journey and do whatever you can do, organize ourselves and keep trying for funding. And if it comes down the line, then great. And if it doesn't, then at least we're doing whatever it is in our power to do. I think the key aspect of any journey is to make a start.
Great. Gert, is there anything you'd like to come in on that?
I guess it's just, as Andy's alluded to, I mean, most of the sort of medium to large sized charities do have significant outreach budgets. They may call them something else in terms of marketing, engagement, etc. My advice is to sort of look at reprofiling that so it has more reach. But I think the examples you'll see is that most grassroots communities want to do the best by their community. So they're only going to ask for a resource that's, you know, fundamental to what they're trying to deliver. But I genuinely don't believe it's money that's the issue. For me, the fundamental issue is about trust and relationships. And until you build trust and relationships, you can be a millionaire, billionaire, whatever, you're not going to make any progress. So you've got to invest the time in building trust, building relationships, and having an ongoing dialogue, rather than seeing this as something as, you know, a good thing to do at the moment, but next year we'll probably move on to something else. I think that's a false economy, and I think it's very disingenuous.
Thank you. One of the questions we have come through the chat is, how do you connect engaged community groundwork like BEMA to action on the wider determinants of health? Can I address that to you to start off, Shaquille?
Yes, so BEMA, as I showed in one of the slides, there were lots of different posters from different projects. So we do a number of different projects. And Andy alluded to in our work with organ donation as well. Initially, there wasn't any funding, but we did get, I think this year, that organ donation project has been funded for BEMA. So I think if you've built trust with the community, people you're trying to reach, and if you've built trust and engage the people who are going to deliver the projects, so in this case could be healthcare professionals who the members of the community will trust, then I think then the funding bit is about really connecting the dots. If you've done a project, like in BEMA, for example, in organ donation, I was actually involved in the very first project in Newcastle, which took place. And that was the only first project. There was no funding. BEMA funded it itself, but it was so successful. We copied the model and delivered it all over the country. And then the funding call came end of last year, I think, and the BEMA did get that. So I guess sometimes the funding comes later on if you've developed a model and a project, and if you've engaged people and built all those strategies to make it successful.
Great, thank you. Gert, do you have any comments on wider determinants of health and small community action, how we can draw from one to the other?
So I think locally, health and wellbeing boards have, I think they've tried to do some good work on this, but I think again, at local level, there is not enough partnership working. So health and wellbeing boards tend to work with what I would call the usual suspects. So there seems to be a group of counsellors who always take an interest in health and wellbeing issues. There tends to be normally large voluntary sector organisations at local level who sort of get a seat at that table. And what I would argue is that we need to make that table much larger and put more seats around it so that you get far more diversity of representation. But I think it's got to be there because the local health and wellbeing boards, they are there to deliver on transport, housing, education, environment, etc. And that for me is fundamentally where those conversations need to take place. So I'm not sure how much input the Local Government Association have into this conference, but I would argue that they are integral to this whole programme of work.
That's a very good point. As a local councillor, I totally agree with you. James or Andrea, would you like to come in on this?
I don't think I've got anything else to add from what Shaquille and Gert have said. Definitely can't add anything more cogent than that.
If I could just come in, Andy's mentioned in the chat we're creating a new role, which will be looking to take this area of work forward. I mean, as an organisation, our roots were very clinical. We were created by clinicians who wanted to see the best standards of resuscitation within the hospital context. We're a tiny organisation. There's only 24 of us, albeit we have tens of thousands of volunteers. And I personally am used to working in small charities with very, very limited resource. So partnership is my default position, never having had an awful lot of resource to work with previously. And I think that's why it's so exciting for us as an organisation to be at this event today, because we have a really, really simple message. But you have the voice. I mean, the clue's in the title of this. And that's the key to it moving forward. So there's almost a blessing in disguise, having recently come from a very big national charity where there was a huge amount of resource. Sometimes there was, as with a lot of big funders, this tendency to go in, concentrate on something for a few years, and the funding comes to an end, and it's not kind of fixed, but we've kind of done our bit and we move on to the next thing, as it were. We don't have that as an option. RC UK is about resuscitation. That's what we do. We've been here for 40 years. We will be here for the next 40 years focusing on that, and we can only do it in partnership. And that's what's going to drive our approach.
Right, and it's something brilliant to bring to this conference. So we're just coming towards the end of this time. I don't know whether we've got the results from the Mentimeter through yet. Oh, here we go. Lovely. So you all contributed your answers, and there's some things coming out very strongly in the word cloud we have here. So in answer to what do you think the priorities are for partnership working to address health inequalities around sudden cardiac arrests, bystander CPR and survival, you've answered education, funding, listening, trust, training, confidence, commitment, and then a few of you have contributed things like understanding, collaboration, representation, communication. I think that's a very good reflection of our conversations here today and what we've heard from all of the panelists, and hopefully we'll go on to have far more conversations like this about partnership working to tackle inequalities over the next few weeks of our conference and into the future as well. Now, just before I hand back to James to close, I'd like to remind you all that at 2:15, please join us for the next member session with Birthrights and Youth Access. We'll be leading a discussion about how to address racial injustice in healthcare, drawing on examples from maternity and young people's mental health. Thank you. Now over to James.
So I'm going to start the way in which I finished. I'm going to start by saying a huge thank you to our friends at National Voices for the kind invitation today, for the brilliant panelists that we've had, Shaquille and Gertch, and Andy. I already knew you were brilliant before today, but you've just confirmed it again. But to the most important people in the room, as it were, those people who have joined us today, because we cannot do it without you. It's as simple as that. We're here. We want to work in partnership. Please don't be a stranger and come and knock on our door. And thank you so much. Take care.